All right, thank you. Dr. Arvind, go ahead, please.
Good afternoon, respected chairpersons and my dear friends. Thank you, AIOS and Dr. RP sir, for giving me the opportunity. So I will be speaking on rock hard cataract, what techniques. So I will be discussing in detail regarding the new technique innovated by our own terminator, Dr. Rajendra Prasad sir, that is terminal chop. So there are many challenges when we are dealing with the rock hard cataract, because there is very high phaco energy is to be required, and these hard leathery nucleus, they are difficult to create a full thickness crack, the first initial crack to divide into two heminuclei, and there are more chances of endothelial burn. There are stress on the granules leading to jonular dialysis and nucleus drop, increased chances of wound burn, and of course posterior capsular rent, and it is very stressful for the operating surgeon and staff also. So we need to look at the Griffith's theory of brittle fracture. So it's a very lean and thin man. He is working on the hard rocks. So he is using the blunt forces at the equator, at the most weakest part of this rock hard. So you can see this is how a lean and thin person able to create a crack, full thickness crack, by using the blunt forces. So this is theory of Griffith's brittle fracture. And now you can see it is divided into two quite easily. So this is a newer technique for nuclear fragmentation introduced and invented by Dr. Rajendra Prasad. It is suitable for medium to hard grade of cataract, and it reduces the surgical time and also the chances of complication. This technique was first published in IGO in year 2016, and we are practicing this technique since 2013 when Dr. Prasad first described the same in a conference. So we have operated over 5,500 cases using this technique. So how this surgical technique is different from the direct chop technique, the direct vertical and the horizontal chop technique. So first we need to have a very good rhexis, then a short superficial central trench of 1 into 1 into 1 millimeter size is created to hold and engage the phaco tip. Then the phaco settings are changed to higher vacuum settings from 450 to 500 millimeter of Hg with 50 to 80% power and 30 to 35 millimeter per minute of AFR. Then the phaco tip is engaged at the distal end of the trench. Then phaco probe is impaled superficially, only superficially, keeping the tip directed towards the equator, parallel to the pupillary plane, not inside, to achieve firm hold of the nucleus just within the equator. Then the equator is drawn within the capsulotomy edge, and under direct visualization, a wedge-shaped blunt olive tip chopper, that is a terminator, is simply passed around the lens equator. Then it is dragged 1.5 to 2 millimeter through the open edge equator to create a small groove. So this dragging generates tension and dispersive forces along the sides of the groove, consonant to drag pick in rock excavation system, and initiates a full thickness nuclear crack. And this full thickness crack traverses automatically across the lens to the other end of the equator and divides the nucleus into two equal halves. So this is the terminator chopper. So it creates a shallow groove with a specially designed chopper and keep the chopper in a lateral position. With both the chopper and the phaco probe, a splitting force at 90 degree is generated, and this is propagated from the equator to center and equator on the other side. The force is working along the brittle lines, and inside out dispersive mechanical forces are used to create the crack. This is how it is done. So it is only a superficial impalement, as you can see in this picture. Now I will show you some videos. So it's a cataracta nigra, as you can see. So this is the specially designed terminator chopper, blunt olive tip. So there is no chance of PCR or posterior capsule damage. So this is how it looks. Right? So at high power and vacuum setting, superficial impalement towards the equator of the phaco probe. Then this terminator chopper goes behind the equator. So all the actions are parallel to the iris plane, pupillary plane. So it is divided full thickness A little bit softer cataract. Only superficial impalement. The terminator chopper goes behind, and you can see very easily into two heminuclei without any fuss. So how it is different from the other techniques? So in the terminal chop, the instrument tips, they move away from each other at the equator, and there is only superficial impalement of the phacoprobe and chopper parallel to the iris plane. Whereas in the horizontal chop, the instrument tip move towards each other in horizontal plane at the equator, and the phacoprobe deeply and towards the optic disc. In the vertical chop, the instrument tip move towards each other in the vertical plane, and the chopper direction is towards the optic nerve. So in terminal chop, it propagates the initial crack into a full thickness fracture in low compressive stress. In horizontal chop, it creates a stressful compressive force, and whereas in vertical chop, there is a plane shearing force with very high stress. So we've published a retrospective study of around 750 cases, also accepted at the ESCRS. So myth versus reality. Some says that it is a blind procedure, but we are doing all the steps and the direct visualization. Some says there are more chances of PCR, but it is comparable. Some says there is more chance of endothelial cell loss and post-op edema. It is comparable or less. So we did the first CTRI ICMR project. We compared this terminal chop technique with the stop and chop and direct chop. So these were already published in IGO. So this is the world first such randomized control trial. So these RCTs are the higher evidence to prove any hypothesis. So now coming to the average cumulative dissipation of energy. As we see in the nuclear sclerosis grade 2, there is no significant p-value difference, although it is slightly lesser in terminal chop, 6.48 as compared to 7.85 in the direct chop and 6.9 in the stop and chop technique. But when the nucleus becomes harder, nucleus grade 3 and 4, you can see this terminal chop technique has a significant p-value as compared to stop and chop and direct chop technique. And there is also lesser ultrasonic time. Thank you so very much.
Excellent talk, and I think without a doubt the terminator has become the way to go for any kind of cataract, soft, hard, medium, whatever. And you have already mastered the technique, so you are teacher of teachers, so there is no doubt that you can
a
show
lot to learn from both of you, sir. I'm always a student.
But the inventor of terminator is sitting here. So we are privileged to have him as the main chief instructor of this show. So this is actually amazing invention, I must say, and you have showed it to the perfection.